So hope I'm audible. Checking. Yes. So welcome friends. Hope I'm audible for you all. So many recall sessions are going on, and I'm one of the session going to do now. Yeah. Thank you, Nagendra. Thank you, Damis. So you all would have realized by the paper, it is a little above average paper. It is little tough only, not so easy paper like previous year NEET. This paper which we had now is having so much of surgery questions. So they have given high importance to surgery. You all know very well from the last year itself there are so many questions in surgery. This year paper also they have given so much of importance to surgery questions. Let us discuss the surgery questions now one by one. So just let me go fast because all of you would have appeared for the exam and all of you will be tired. I will have a detailed discussion session later. Let me give you fast revision now. So Q so far score is fine. We had around 32 questions, 32, 33 questions, straightforward surgery question only from Bailey and Love. Directly I'm having a Bailey and Love book here. All questions are there from Bailey and Love, directly asked from Bailey. So Q so far score includes RCB. I always used to tell Royal Challengers Bangalore sitting in the sofa. Respiratory rate more than 22. Confused status which is given by Glasgow Coma scale, and BP, systolic BP less than 100 millimeters mercury. So this has been asked in the exam. I hope 100% all of you would have answered this question absolutely correct. So this question is a very easy question. So and it is a one repeat question. So now let us count how many questions got repeated and how the paper level in surgery. So this question is a 100 times expected MCQ before going for the exam itself. And Q so far score, you should never have made a mistake. So respiratory rate more than 22, confused status, systolic BP less than 100. So let me discuss fast. I'll try to finish the session in 1 hour so that you can go and look after your other works and enjoy the post-exam thing. So I will discuss this session, detailed session after complete preparation of the choices. So please don't forget Q so far score. And there are two questions from Fournier's gangrene and there are two questions related to Fournier and Melini's gangrene. So I'm not able to get the exact question. But there are two questions, I'm sure. But if you have any doubts, you can always post me. I want you to remember page number. Please remember page number 456, 457 of Bailey and Love, 28th edition. The questions are asked line by line without a single change of statement. This has come from this chapter. This chapter is disaster surgery chapter. The disaster surgery, that is a chapter in Bailey and Love. From this question, two questions have come. Alternately two questions. From necrotizing fasciitis. So, necrotizing fasciitis, please remember the important points because I could not get the proper recall. I'm telling you what are the points to be noted in necrotizing fasciitis. So, necrotizing fasciitis is a rapidly spreading infection of the subcutaneous tissues. It rapidly spreads continuously in the underlying areas and it is formed by polymicrobial organisms, not by single microbial. It is a polymicrobial organism. Both aerobic as well as anaerobic organisms are present. See, very interesting point in necrotizing fasciitis is when you see the skin, sometimes the skin will be normal, but beneath the skin, the tissue will be, the deep fascia and underlying tissues will be extending like this. So that is why when you see Fournier's gangrene or Melini's gangrene, I hope you know what is Fournier is. Scrotal gangrene. Melini is abdominal gangrene. In all these cases, when you see the abdomen wall, it may look normal. When you put your finger inside, it will be having a lot of fluffy tissues inside. Okay, it will keep on going underneath. So Fournier gangrene and Melini's gangrene are two important types of necrotizing fasciitis. I want you to remember, and there are so many important points here updated in New Bailey. These patients will need a extensive debridement. Extensive debridement will be needed. Giving debridement should continue to the normal tissues, at least 1 centimeter into the normal tissues. You have to do debridement. And very important line, the straight line is there in the MCQ exam. After 24 hours, you have to re-explore. So re-exploration will be done after 24 hours. That line is there in Balian law. So um, so this is it's around 24 hours re-exploration has to be done for these patients, and most important is this has to be repeated every 24 hours again and again. We might need to repeat this re-exploration. And about hyperbaric oxygen therapy. So hyperbaric oxygen therapy is used. Please remember, it is updated in New Bailey 28th edition. Hyperbaric oxygen therapy has role. It is having role. It decreases mortality. So we were usually thinking that it will be used only in Clostridium infection, but very clearly Bailey has updated in this line. There is a clear-cut line, page number 456. It has updated clearly. We can use hyperbaric oxygen therapy can be used. So I don't know how many of you have attended this exam, and from the exam, the questions, please understand this topic is again and again a favorite topic now. Necrotizing fasciitis. Necrotizing fasciitis involving the scrotum is Fournier, involving the abdominal wall is clear cut Melionis gangrene. So bladder diversion may be done with, mostly it is not needed because it will not infiltrate the bladder. It is caused by mixed organism. Archidectomy may not be needed because there will be shameful exposure of testis. Shameful exposure of testis will be present. The testis will not be involved. Anti-gas gangrene serum is not used. And answer E, hyperbaric oxygen therapy can be given. I think this is two questions asked in the exam. There are two questions. So thank you, Raj, and thank you, Himanshu. Please follow the questions. So the point here you should remember is, please remember, these are the points taken directly from Balian law. Every line is directly from Balian law. Patients are usually immunocompromised, and please don't forget, this is a rare but serious bacterial infection that affects spreads via the deep fascia. It spreads via the deep fascia. Hence, it is known as fasciitis. It's a mixed organisms will be present, and most important, the subdermal spread of gangrene is always much more extensive than that appears from the normal examination. Finger test, there is one test known as finger test. You can put that finger and see inside. You can see the necrotic tissue. This line is expected in future exam. Dishwater color fluid is noted. Dishwater color fluid is noted seeping from the wound, and gentle probing maneuver with the index finger with a sterile glove is provided at the level of deep fascia. You have to do a gentle probing maneuver, that is known as finger test, and there will be no vascularity will be seen. So that's our classical findings. Rapid frozen section analysis if positive, or finger test is positive, we will go for immediate operative treatment. So operative treatment involves extensive dissection of the tissue. So please don't forget this point. Second question. So third question is again a repeat question. So this is another repeat question. So first, second, if you are seeing this is not a repeat question, please remember this is a direct repeat question of FMG exam 2023 January exam. Same question came without even change of choice. The same question came. So question 1 is a repeat. Question 2 is a repeat question. Question 3 is a very basic repeat question. Opening of eyes to the pain is eye opening 2. Okay. Inappropriate words is V3 and withdrawal is M4. So this again a repeat MCQ from Glasgow Coma scale. So any topic if you feel you need to be explained, please tell me. I will explain them. But I wanted to just, for those who have appeared for the exam, I wanted to give a fast, correct answer so that they will get an idea how much they have answered correctly. Therefore, I'm going a little fast about the questions. So question number 4 is again a repeat question. See, I'm telling you which are all repeat questions. I'm marking as R. These are all repeat questions already asked in the exam. A patient developed acute chest pain. So whenever there is a chest pain, starting from here, radiating to the center of the back, and when you are measuring the 2 BP in the two limbs, please remember, this is the aorta. This is a dissection which happens. If this limb BP will be normal, right limb BP will be normal, whereas left limb will have hypotension. So this is very classical finding of aortic dissection. It is an easy question actually. This question was asked in FMG exam with a tennis ball appearance on CT angio. CT angio will show what finding? It will show you tennis ball sign. Tennis ball appearance is seen on CT angio in an aortic dissection. So aortic dissection, please don't forget, is a very important MCQ and it is regularly asked in every exam. So question number 4, it is aortic dissection. It's a repeat question. So question number 5, these are all very basic questions. You should not worry about whatever history given there. There is a history of surgery and etc. etc. Don't worry about it. It's a clear-cut case of keloid in the chest. So keloids usually happen on the extensor surfaces, not on the flexor surfaces. On the extensor surfaces, you will get a keloid. So this is a classical picture of keloid, which will have extension into the normal tissues from the original scar. They extend into the normal tissues. They have proliferation of immature fibroblast. Immature fibroblast. So this question is also a repeat question. So you can see 5 questions I have discussed so far, all are repeat questions. 6th question is again another repeat question of EDH. EDH, there is a history of trauma and the patient had a biconvex hematoma. You don't worry about history at all. The patient had a CT scan image given that is showing you biconvex hematoma. So when there is biconvex hematoma, it is EDH only. No doubt it is EDH only. Okay, this question is again another repeat question. So intraosseous route administration is also given as another image in pediatric patients. In pediatric cases, when you could not access IV line, like we cannot access in a trauma. In a pediatric cases in trauma, I could not get an IV line like a cubital vein, or I could not get into femoral vein or long saphenous vein. I will go for intraosseous route at the level of tibia or at the level of humerus. So these are the 2 bones where we will infuse fluid directly into the intraosseous route. So this is another image which is asked in the exam. So I hope it was. So any other question related points, please post. I will rectify, because I will also note those corrections. So this is 7th question. So in a general aspects, so in the first 7 questions, in the general aspects, there are totally, we are frustrated seeing there are no questions from suture materials, there are no questions from surgical site infection, there are no questions from nutrition, nothing. So everything was totally absent. Even trauma had only 2 basic questions, that too GCS and EDH. And general question, anyhow, out of 7, all the 7 questions are repeat questions only. In general surgery, it is general aspects, it is out of 7, all are repeat question. So most of you might have felt, what is this? It was not SDH. Yes, they told the image was EDH image, biconvex hemorrhage. By concavo-convex is SDH. SDH will have concavo-convex. Concavo-convex is SDH. So even if you are attending this video after this live session, please post your comments so that I will also verify the comments and I will update it accordingly. Okay. So there are 7 questions asked from general aspects. Mostly they are all repeat questions. Let us discuss section B, head and neck, thyroid, breast and hernia now. So an intern was given intern image. Her oxygen was shown with an exophthalmos image. He is agitated and tensed. What is elevated? So it's again a straight line from Bailey-Love. Answer is anti-TSH receptor. Okay, this is a Rupu Sharma. I don't know, but most of the students told it is biconvex hemorrhage. So I'm telling it is EDH. If it is concavo-convex in the image, it is SDH only. So it depends upon the other students what they are going to tell. So how to clearly identify the image. I don't think there will be a controversy in EDH and SDH. So this is a line from Bailey and Love. The whole of the functioning thyroid tissue is involved in the hypertrophy and hyperplasia are due to TSH receptor antibody that bind to TSH receptor and produce disproportionate and prolonged effect of thyroxine production. So the answer is very clear-cut straight line from Bailey and Love. TSH receptor antibody is elevated. Among these antibodies, which is elevated is the question. It is anti-TSH receptor antibody which is elevated. Okay, please don't forget this. And what is this therefore it is a little repeat question only. If you would have gone through that, you would have answered this question. That's actually a next question. The following is good prognostic factor in a Birat's 5 lesion. See, I have not given the complete history and all. I have just given directly the MCQ points for understanding purpose for last minute to know the answers. So the following is the good prognostic factor. Welcome, Divagar, welcome. So the following is the good prognostic factor in Birat's 5 lesion. So this question is again, which is good prognostic factor? ER positivity is good prognosis. P53, Ki67 are all bad prognosis. This is again another question from the new edition Bailey, page number 942. There is a straightforward question on prognostic factors of cancer breast. So which are all poor prognostic factors? HER2 is a poor prognostic factor. Triple negative is poor prognostic. Lymphovascular invasion is poor prognostic. High Ki67 is poor prognosis. Extensive DCIS component is poor prognosis. And very clearly, New Bailey has updated everything about the Nottingham's prognostic index is used to determine prognosis following surgery. It is calculated using tumor size, lymph nodes, tumor grade based on these three: size, lymph node, and grade. Size, grade of the tumor, and axillary node. Based on these three, we have an index known as Nottingham's Prognostic Index from new edition Bailey. So 28th edition Bailey. This exam had some questions specifically from 28th edition Bailey. So we thought there will be no questions from 28th edition, but they have asked clear-cut, straightforward points from 28th edition Bailey. So therefore, in INI CERT exam, you have high chances of getting more questions directly from 28th edition Bailey. Okay, so please remember this question. So next question. So I am discussing the important questions. Deep ring is a defect in which layer? Okay, defect in which layer? This is again an applied anatomy question. So you all know very well. This is a clear-cut question of deep ring. So there are two questions came from hernia. Let me discuss them. This is anterior superior iliac spine. This is pubic tubercle, and this is rectus abdominis muscle. This is rectus abdominis muscle. This is inguinal ligament. And you know, this is the deep ring, this is superficial ring. Superficial ring is a defect in external oblique aponeurosis. External oblique aponeurosis. Deep ring is a defect in fascia transversalis. It's a defect in fascia transversalis. This question came very straightforward anatomy question. And Hasselbalch, this is an inferior epigastric artery. And you know very well, this is Hasselbalch triangle. Hernia happening through this triangle is known as direct hernia. So why direct hernia happens? Direct hernia happens because of the weakness of the muscles here. What is the muscle here? The muscles in this area becomes weak. That is why we keep a mesh and close it. This muscle is known as conjoint muscle. Our conjoint tendon becomes weak in old age. That is the reason for formation of direct hernia. So the reason for direct hernia is weakness of conjoint muscles. Conjoint hernia, conjoint muscle weakness is direct hernia. And congenital direct hernia, I hope you will be remembering this. Congenital direct hernia is due to defect in dash conjoint tendon. Please don't forget, there is usually direct hernia is acquired. Congenital direct hernia is due to defect in conjoint tendon. Please don't forget this point. What is a hernia happening in? Defect in lacunar ligament. If there is a hernia happening via lacunar ligament, it is known as laguar hernia. See, these are all very basic questions which you would have read in your final year days. You might have forgotten now. But conjoint tendon, if there is a defect, that is direct hernia. Lacunar ligament, there is a defect, is laguar hernia. Okay. So the deep ring is a defect in fascia transversalis. The simple question, simple repeat question. Okay. Hernia medial to inferior epigastric artery is due to weakness of conjoint tendon. Another repeat question. See, I'm giving a fast review of those who have attended multiple sessions here and there for recall sessions. I wanted to give the exact correct answers based on 28th edition, the fast review. Anything, if you feel controversial, you can post in the chat box. I'll be answering them in the chat box. Post-lap hernia, a patient complains of pain in the nerve injured is. So post-lap hernia, laparoscopic hernia was done like TAP operation or TEP operation. I hope all of you will remember. We will do operations, and in this we will dissect the two triangles, the triangle of doom and triangle of pain will be dissected, and during this operation, one of the nerve in the triangle of pain can be damaged by a tacker. That nerve is known as, what is it? Lateral cutaneous. So remember, lateral cutaneous, L for L. Open, you will injure ilioinguinal nerve. Don't forget, open surgery, we will injure the ilioinguinal nerve. In a lap surgery, we will injure the open ilioinguinal nerve. Lap surgery, lateral cutaneous nerve will be injured. Please don't forget the nerves which are injured in various types of operations. See, these are all very easy questions. These are all repeat questions. Hernia, incision, sutures, things. A swelling in the neck moves with the protrusion of tongue. So, it is another simple, easy question which is well-known answer, thyroglossal cyst. So, please don't get scared with the history, what is given there, what is the things which are given in the explanation. It is a straightforward question with the movement of the protrusion is thyroglossal cyst. Okay. Pain in the parotid swelling. I could not get the exact question of parotid swelling. I heard there is a question asked from the parotid swelling. Pain in parotid swelling is due to infiltration of the nerves. So when you get a pain in the parotid, it is mostly due to the, usually parotid tumors are painless. Please don't forget that. Parotid tumors are painless. It is
Adenoid cystic cancer, it is adenoid cystic type of cancer which infiltrates the facial nerve and causes pain, severe pain. As it infiltrates the facial nerve, it will cause pain and it will have perineural infiltration infiltrating up to the skull. It will go into the skull and it will infiltrate even into the brain. Please remember, therefore, the pain in parotid tumor is due to infiltration of facial nerve. So, please remember facial nerve infiltration. So, these are the questions from section breast, thyroid, hernia, parotid. They have given equal number of questions. We have around from 6th question to 12th question, we had around 7 questions, and all the 7 questions are little easy questions only. So, I can say the first section, trauma and general aspects are very basic question. Most of them are repeat. Section B, this section B containing thyroid, breast, hernia also had some simple question only. So, which nerve is infiltrated? The question is asking about which nerve means if it had facial nerve, go for facial nerve. If it infiltrates, facial nerve will be the correct answer if it is there in the choice. Parotid swelling will cause pain only when it infiltrates into the facial nerve. So, please remember that. Okay. So, coming to the section C, GIT. The examiner who took the question probably was preparing for surgical gastro entrance exam. He had taken questions of NEET SS gastro exam questions. All the questions asked in GIT are not NEET PG questions. These are all very commonly asked NEET SS questions. We used to discuss all the questions in NEET SS exam. None of the questions are from NEET PG level and none of the questions are from Bailey. Please remember, all the questions in NEET SS are from Sabiston. Gastro questions are all taken from Sabiston. So, I am sure by seeing the gastro questions, most of you would have got scared and you would have thought the paper is tough. But until so far, general, trauma, thyroid, breast, all are easy paper. Coming to GIT, the problem starts now. A patient consumed alkali and has severe dysphagia. What will you do? So, I will tell you a practical question. This is a case of corrosive alkali ingestion. Corrosive alkali ingestion will cause liquefactive necrosis. This is the maximum MCQ you know from this. So, liquefactive necrosis is caused by alkali consumption and they will cause damage of the esophagus. Usually what we will do, if a patient comes to you with the dysphagia, as surgical gastroenterologists, we don't do anything in this place. We allow that esophagus to heal. We don't do anything there. We will directly go and do a feeding jejunostomy at this acute phase. What is done in acute phase? That is a question that should be added here. If a patient is in acute phase having severe dysphagia now, I will go for feeding jejunostomy. That is the correct answer here. So, I am telling you, definitely Shivareddy, most of the points I have covered from Sabiston, but questions which are asked are all directly SS level questions. So, we have covered liquefactive necrosis, we have covered corrosive, everything, but the point is they are asking questions from super specialty question bank. These are all super specialty question banks. We cannot read. But the one point you should remember here is when some question is tough, it is a tough for everyone. This is a competitive exam. Definitely there should be some 5 to 10 tough questions which can decide the readers who read in depth of the concepts. So, definitely these questions, 98% of them will not answer most of these questions which are asked in GIT. So, GIT, all the questions are from Sabiston. We have discussed all questions from Sabiston, but all are asked from Sabiston based NEET SS question bank. It's not NEET PG level, all are SS question bank. So, this question, to understand this question, you should have treated a case of esophageal damage by corrosive. So, the answer is feeding jejunostomy. None of this will come. So, therefore, this question is number 1, new question. This is the first new question among the 15 questions I have discussed. Second question is coming. A patient presented with hematemesis and melena, occasional alcohol intake. He is having history of aspirin. I am not sure what is the complete question what you are asking in this question. So, I will tell you what are all the causes of hematemesis and melena now. So, a patient comes to you with hematemesis and melena, occasional alcohol intake. So, I will rule out variceal bleed. So, he cannot be a patient of bleeding. History of aspirin. History of aspirin will cause what problem more? More it will cause erosive gastritis. Please remember, erosive gastritis is more common with history of aspirin consumption, not peptic ulcer. Peptic ulcer is because of some other reasons like duodenal ulcer is due to increased acid production, etc. But erosive gastritis can be an answer in this question. So I don't know the exact choices which were given, but let me tell you, upper GI bleed. Please understand, upper GI bleed. Upper GI bleed. Again, this topic is not from Bailey and Lau. Please remember, it is also from Sebastian only. All the 6 gastro questions are from Sebastian. All the 6 questions are new questions. 99%, most of them would have gone in these questions. So they are due to duodenal. We divide the UGI bleed into 2 types. One is variceal bleed. And another is non-variceal bleed, which is common. Can you tell me? One is variceal bleed, another is non-variceal bleed. Variceal bleed is only 20%, non-variceal is 80%. And in this non-variceal, which is common, is the most common is duodenal ulcer, 60%. Then duodenitis, duodenal ulcer, Mallory V star, Dilophois lesion, gastric antral vascular ectasia, erosive gastritis, Cushing ulcers, so many other things will come under this. So how to know what is correctly means? If you go through the books say NSAID consumption will cause erosive gastritis is very clearly mentioned even in Bailey and Lau. It is very clearly mentioned the erosive gastritis will cause bleeding in NSAIDs. If it is a duodenal ulcer, I feel the patient would have had a old history of ulcer will be there, like that they would have mentioned. Okay, they would have mentioned something like that. Okay, therefore this question, there can be chances of it can be an erosive gastritis. Question number 14 can be an erosive gastritis. We have to wait and watch for the complete recall from some students. Question number 15 is another question probably taken from pediatrics book, not in surgical books. A boy comes to you with a rectal polyp having bleeding. The biopsy shows mucin and large number of giant cells. So the most common cause of bleeding per rectum in young boys is what? Polyps, rectal polyps. And the rectal polyps are usually hamartomatous polyps. Hamartomatous polyps like what? What are the syndromes which can cause hamartomatous polyps in the rectum and colon? JPS, juvenile polyposis syndrome. PJS, Peutz-Jeghers syndrome. So these are syndromes which will cause hamartomatous polyposis. Such a large amount of mucin and large amount of giant cells is, these wordings are coming means definitely it is not from our books. It is taken from Robbins pathology or some other pathology book. So it's an applied pathology question. I hope you will be discussing this with the pathology faculty. So this question is a complete new question, but it is this question following APR surgery and nerve injured is at least some 25 times, 30 times asked NEET SS question. So if I explain this question, you will understand this is a complete NEET SS question which will never be read by NEET PG aspirants. Even NEET SS aspirants, gastro aspirants only will have a clear idea on this APR and nerve injuries. Let me discuss now. This is the rectum. Please remember, this is rectum I am now drawing. Anus, and this is the pelvic bone, and this is sacrum. This is the sacrum. Okay, sacrum. Now I am going to draw 2 important nerve plexus. You are going to see very interesting nerve plexus. You are going to see 2 nerve plexus. Number 1 nerve plexus. See here. This is a very important plexus seen presacral plexus. This is a nerve plexus known as presacral plexus. This presacral plexus, they will join and form one nerve known as hypogastric nerve on both sides. This is hypogastric nerve. This is the MCQ asked. Without telling the name, they have asked you about this nerve only. Hypogastric nerve is a very important nerve which is derived from this presacral plexus, also called as superior hypogastric plexus. Superior hypogastric plexus. When will this plexus get damaged means when I am ligating the IMA, this is IMA arising from aorta, when I am ligating the IMA close to the organ, high ligation of IMA. High ligation of IMA concept is now removed because of this prevention of this nerve damage. High ligation of IMA, which is arising and supplying the left colon. When I ligate here, I can injure this presacral plexus or hypogastric nerve, which is carrying what system? They are carrying sympathetic nerves. They are carrying sympathetic nervous system. So when a sympathetic nervous system is damaged, I hope you all know what will happen in a lumbar sympathectomy. The patients will develop retrograde ejaculation. So hypogastric nerve injury can cause retrograde ejaculation is the answer for this. So they will develop retrograde ejaculation. There is another plexus also. See, there is another plexus also that is known as this plexus. Inferior hypogastric plexus on both side of the rectum. There are inferior hypogastric plexus also known as lateral plexus or inferior hypogastric plexus. So these plexus can also get damaged when you go very laterally, but very rare. When you go very laterally and cut, you will damage these nerves when I am doing an APR. And if I damage these nerves, this will result in atonic bladder and impotence. Very dangerous. Impotence is more dangerous. The patient will not get an erection at all. Retrograde ejaculation, they get erection, but only the sperm will not come antegrade. So retrograde ejaculation is an accepted complication. But if you injure the lateral plexus going very laterally towards the pelvic wall, you will cause atonic bladder and impotence. And this is having both the sympathetic and parasympathetic plexus. So this is a question which is asked, very important question. I told you, this question is a NEET SS question which is not at all discussed in any PG exams. Only for NEET SS exam we discuss this question. This is asked in the exam. So I will vote in this question for retrograde ejaculation. Sympathetic plexus damage with a retrograde ejaculation will be the correct answer. In an APR, hypogastric nerve will be injured. Please remember, hypogastric nerve will be injured. That is APR. This is another question. So you can see we had only some four questions from GAT. All are totally new questions. All are Sebastian based questions. HBP is okay, not so bad. Hepatobiliary questions are little average questions, not from Sebastian. Most of them are from Bailey law. Clonarchy sinensis, what cancer it causes? It causes cholangiocarcinoma. Is caused in Clonarchy sinensis. Please remember. In cirrhosis, the anastomosis happens between which veins? Another simple question. So all of you would have answered this correctly. I'm sure you would have answered this. So you all know very well, in a portal hypertension, this is a portal hypertension. This is superior mesenteric vein, portal vein, splenic vein. And when the pressure in the portal vein increases, so many other collaterals open. One of the most important collateral they are asking. That collateral is this. What is this vein? That is left gastric vein, also known as coronary vein. Because of the high pressure in the portal vein, will go up and will open in the lower end of esophagus by joining with the lower esophageal veins known as azygous veins. Azygous venous system it joins and forms the esophageal varices. So that is the question. So the left gastric vein gets anastomosed with what? Lower esophageal veins known as azygous veins. Similarly, it can form collateral in many places. In many places, it will form collateral. This is one of the important collateral scene. It can form collateral in the rectum also, in between the inferior rectal vein. So the superior rectal vein is a portal vein. It's a part of portal vein, the inferior mesenteric vein. IMV continues as superior rectal vein. This will form a collateral with the middle and inferior rectal veins, which are systemic veins. So superior rectal vein anastomosis with middle rectal vein or inferior rectal vein. This is another place. Similarly, you have collaterals formed between many places. Simple applied anatomy question. I am not sure this is a surgery question, but it is an applied anatomy question. Your anatomy faculty might have taken this, please remember. But we used to take this in portal hypertension topic always. Okay. Always we used to take this in portal hypertension topic. So which anastomosis happens between which veins in cirrhosis is esophageal azygous vein and with the left gastric vein known as coronary vein. Okay. Treatment of liver abscess 75 ml in a patient who had diarrhea. So this question is asked about diarrhea patient. So I am requesting you, even after you are watching the videos later, you can post the queries in this chat box. I will be replying your queries definitely. So 75, and we will do a detailed recall session of all the topics in depth from based on Bailey and Love and Sabiston in future. So liver abscess 75 ml. So liver abscess 75 ml means definitely whether it is an amoebic abscess or even it is a pyogenic abscess, whatever the abscess may be, I should only aspirate. Percutaneous drainage should be done. So here we all will be thinking it is a diarrhea, so it will be an amoebic abscess. See, amoebic abscess more than 5 centimeter size will need drainage. This is a direct indication from Sabiston. Any abscess more than 5 centimeter will need drainage. By chance in the choice PCD is not given, we will go for injection Metrogyl for 14 days. 750 milligram for 14 days will be given the answer. If amoebic abscess, if Metrogyl is given, if PCD is given, that will be the best option always. So 75 ml is a big amount, it can rupture. So size of the cavity more than 5 centimeter will need drainage. I think pair is another question, that question is coming up. There is another question pair. So this question is very simple, straightforward question. Again, it's a repeat question from Sabiston. It is a Sabiston based question. This is a pancreatic duct. I am telling you, this exam paper was set by one fellow who is preparing for SG entrance exam. Super specialty surgical gastro entrance exam. Most of these questions are 100 times asked SG question. They are all not new questions. These are all repeat SG questions. This is a pancreatic duct which is dilated with the stones. What I will do? I will open the duct and I will anastomose the bowel like this, known as what surgery? Actually, they didn't even ask the name. The name of the operation is Pusto, known as lateral pancreatico-jejunostomy. We have to do a lateral pancreatico-jejunostomy. Pusto operation will be done. That is the question number 20. Question number 21, you can see this is a CT scan showing you water lily appearance known as CE3 in CT scan. CE3 in CT scan, there is a water lily appearance. This case will need pair. So the first line treatment for this case, I don't know whether they asked first line treatment. First line treatment will be pair, will be the first line treatment. We have to try with the pair. So first line treatment of a hydatid cyst like this with the floating water lily membrane is pair. This answer is pair. There are two questions. A baby presented, a newborn baby with a jaundice and IHPR as a collection in the ducts. So newborn baby with a jaundice and IHPR dilatation. So inside the liver, the bile ducts are dilated and there is collection in the ducts like this. And this is the atresia duct. We have taken a liver biopsy. Liver biopsy shows, this is a one line answer. This line is enough. Bile duct proliferation is seen in EHPA. Extra hepatic biliary atresia. This is again a Sabiston question. Again, all these are Sabiston question. Direct line from Sabiston. The word bile ductular proliferation is because of the obstruction here. The bile ducts in the liver will proliferate, will become more and more. That is known as bile duct proliferation. Yes, it can happen in 4-month baby also. 4-month baby. Up to this cases can come to you up to 6 months. So 6 months the EHBA can happen. So please remember this point. So this is EHBA. Yes, definitely I am telling you, this paper, not only this paper, there are many papers which are very clearly making you realize there will be more and more importance to clinical chapters and clinical books only. So you have to raise your standards in 3 subjects: medicine, surgery, OG. Because when next is going to come, the 3 subjects which are going to be very depth questions will be coming is from medicine, surgery, OG. So you have to read these 3 subjects. I am sure these 3 subjects you all would have experienced so many tough questions. Actually, when you ask a surgeon, surgery PG, or a surgeon or a OGian who have been already completed the OG, they will tell they are all very common questions of PG level and they are very basic clinical questions. Most of them are simple clinical questions. So you have to spend more time on these subjects: medicine, surgery, OG. Other subjects I am not saying not to read, but you have to read those subjects when you are reading surgery. When you are reading surgery, you have to open and read applied anatomy, applied pathology like that. You do not go and read pure pathology or pure physiology or pure biochemistry, not needed. That question have not come. You all know very well. The number of questions repeated this exam, most of you would have realized, and it is you who should tell your juniors how to prepare for the exam in future. So last year also the same thing happened. Last year we had 50 questions from surgery. 50 questions from surgery. This year we had around 40 questions. Alcoholic patient with increased AFP. What's the diagnosis? Diagnosis over. Alpha fetoprotein elevated in HCC. So there is a question on HCC based on increased alpha fetoprotein elevation. So these are the questions from HBP. HBP and GIT and HBP. Actually, these are the two sections which were tough because most of the questions were NEET SS questions asked in the exam. But they are all very commonly repeated NEET SS questions. And these questions, out of this around 12 questions, only 4 to 5 questions most of the students would have answered. So don't get scared that you have not done good in this paper, because I am telling you, any topmost student who have prepared from surgery also would have not answered more than 5 in this GIT HBP section, because most of them are completely new concepts and not asked and not discussed in any of the Bailey and Love related topics. So these are highly expected Sabiston questions which we always discuss in NEET SS exams. Okay. So now coming to specialty. Specialty is very easy paper. Specialty paper, usually they won't ask this much number of questions in specialty. This time they asked enormous questions in specialty. So CEAP classification of edema in the limbs, you know very well. C1, C2, C3 is edema. I don't know whether they asked edema. C4 is pigmentation. I don't know which one was asked in the exam. So if it was a pigmentation, it is C4. If it is edema, it is C2, C3. C2 is varicose veins. C1 is reticular veins and telangiectasis. So I hope you all would have read the last minute classification. This is a highly expected question always. Okay, please remember this question. Putty kidney image was asked already multiple times. Repeat question. Putty kidney is seen in chronic TB. So chronic TB, putty kidney was again asked. And this is a question very clearly given. A lesion in the penis with no lymph node. See, it looks like a cancer, but there is no lymph node. What do you think will be the answer? What do you think this case will be? This is a case of either Buschke-Lowenstein tumor. Either it is a case of Buschke-Lowenstein tumor or a verrucous cancer. Both of them will be appearing like this with no lymph node. Such a big lesion, we always go for partial penectomy. The treatment of this lesion is partial penectomy will be the best answer for this question. So partial penectomy. We will not treat these cases with a CO2 or laser with other choices. So such a big tumor, we have to go for partial penectomy. Okay. So this is an ulcer. You have to know the 3 ulcers. The 3 ulcers, let me discuss for those who are preparing. This ulcer is a question of, you all know very well, ulcer is a question of MBBS days. Ulcer in foot. So what are the ulcers you get in foot? Number 1, all of you know varicose ulcer. You will never have a doubt in a varicose ulcer because it is also known as venous ulcer, always seen on the medial malleolus. It is also always seen on the medial malleolus. Okay, therefore it will not be a doubt. If you have a venous ulcer, you will immediately answer. So they have given verrucous cancer means no issue, Prasanna. That is, verrucous cancer means undoubtedly you have to go for, eczema means it is C4. Okay, eczema, Ashwin Balaji, if it is eczema, C4. And if it is verrucous cancer means no doubt partial penectomy. I was wondering whether it would have been a Buschke-Lowenstein because Buschke-Lowenstein will not always need a thing. Okay, and ulcer in the dorsum of foot. Okay, ulcer in the sole of the foot is different. I am telling you the ulcer in the dorsum of the foot like this. What ulcer will happen on the upper aspect of the foot? This is usually a arterial ulcer. Any ulcer you get in the upper part of the foot, that is nothing but any punched out ulcer. It will be a punched out ulcer is arterial ulcer. Venous ulcer will be a sloping ulcer. Sloping ulcer is venous ulcer. So what is then other ulcer? The other important ulcer is tropic ulcer. Tropic ulcer is an ulcer which is seen due to neuropathy. No nerves, no sensation is there. No sensation. So what will happen? These people will walk very casually on a bony surfaces. The bony surfaces will start getting ulcers. So this is common on great toe, on the sole. It is always seen on the sole. It is seen on the sole, in the grade 2, calcaneum. In all these places, you get tropic ulcers due to neuropathy. What will be the diabetic ulcers? Diabetic ulcers are the worst of all because it is a mixture. Diabetic ulcers are mixture of neuropathy plus vasculopathy. Neuropathy plus vasculopathy. Both will be present. So they can happen anywhere, and most important in diabetic foot ulcers, they can happen anywhere in the foot, sole or in the dorsum, wherever it happens. If you see an ulcer in the diabetic, if you see an ulcer like this, if the ulcer actually will be extending underneath, the skin may look normal, but ulcer will be extending underneath. We have to do debridement, go deeper, deeper. So diabetic ulcers, very important, diabetic ulcers will be extending underneath. Don't forget it. Okay, it is a mixture of neuropathy and vasculopathy. They have gangrene plus foul smelling. It is because of associated infection. Because of associated infection, they will be having a foul smelling odor. Whereas this tropic ulcers will not have foul smelling. They are not infected. They are only dry areas. They are not infected. So they won't have that foul smelling, bad infection and all will not be present. So please don't get confused with ulcer. Any ulcer on the grade 2 or in the calcaneum, undoubtedly it is tropic ulcer. Okay, tropic ulcer. So this is a baby MCQ again, a patient coming to you with a Pancoast tumor. The choices given had ptosis, etc., etc. This is a Pancoast tumor. This is a picture of Pancoast tumor, which is a type of squamous cell cancer. Squamous cell cancer presents as Pancoast tumor. Two questions came from lung cancer. One is this image of Pancoast cancer, and another is a lung cancer in a smoker with hypercalcemia as a paraneoplastic syndrome is squamous cell cancer. If the question had a patient with the paraneoplastic syndromes like Eaton-Lamberton syndrome, SIADH syndrome, ACTH induced Cushing syndrome, it will be what cancer? It will be small cell cancer. So hypercalcemia is the choice. So I went for squamous cell cancer. It's a case of hypercalcemia is squamous cell cancer. Okay, that is a 31st question. So these are the various questions asked in the exam. I'm sure with all these questions, I'm sure the surgery questions we had around 35 to 40 questions are clear-cut surgery questions. I am still in search of the questions and detailed explanation of this 35 to 30 questions. 25 questions if you have answered, you are going to do good score you are going to get. 25 out of this 35 to 40 is a good score if you have answered. Definitely 1 or 2 or 3 or 4 you would have made negative. Don't worry about it. So definitely this paper is a little tough paper with related to surgery. I am not sure with other things because in surgery GIT and HBP are totally asked from Sabiston, not from Bailey. But other questions are all very, very basic, easy questions from trauma, general, thyroid, breast, all the areas they have touched very, very perfectly. All area questions are being asked in this exam. So the commonly expected areas are not asked like achalasia cardia, like cancer stomach, like colon cancer, all those things like ulcerative colitis, Crohn's disease. These are all being not at all touched by these examiners. Like gallstones. See, gallstone is such an important topic, but they have not touched it. They have not touched a gallstone. They have not touched about the various essential areas of CBD stone, cholangitis, bile duct injury. All those things they have not touched in this paper. So any other doubts if you have, please tell me, or else I will come and meet you soon in another session with a detailed discussion of whatever I have collected. But I request you, please post your doubts either in this place itself, or you can come for discussion in my Telegram channel. In my Telegram channel, you can always post. Telegram Surgery Sixer is the Telegram channel. You can join here, or you can join Instagram. In Instagram, I will be discussing all the questions in scrubs with RRM. This is a group name. Scrubs with RRM is a group name. I will be showing you all the videos, all those things. And there are no video question. Another important disappointment for me is there is no small gift video in surgery also. So these are the important questions. So I hope you all have done well. So don't worry, just relax. I am sure whatever hard work you have put will definitely fetch you a good rank which you have been dreaming so far. Okay, all the best. So any more doubts, I'll be waiting for you, or else we will back up. So we'll come up with the soon another session, detailed discussion session will be soon done. Okay, you are requested to post any things and all, you can post here. Thank you Subhash Groy sir. I think some of the NEET SS aspirants are also attending. Thank you Himanshu sir, Himanshu. Thank you. That means most of you are not having any doubts, and I think most of the students who wrote the exam have not yet seen the video because they are all already attending. Many other sessions are going. I announced this session in an emergency and I arranged the session very fast. I think most of the students who are attending other sessions will come and see this video, and they will come further with the queries soon. Thank you. So thank you so much. So we will soon discuss the updates from Bailey and Low, because there are so many updates from Bailey and Low which are to be updated because so many points are there. Yes, Shiva Reddy, we are covering always for Sabiston important areas, we are covering all the time. Don't worry. Thank you.